in the world of fetal surgery. We are doing most of these techniques here in Cincinnati, having a lot of experience, and also doing a lot of research, trying to progress and implement innovation. So I will try to share my screen right now. Hopefully it works. And okay. So the first question when we need to talk about fetal surgery, mostly for people that are not familiar with this, is why fetal surgery? What's the reason of fetal surgery? And the answer of this is very easy. It's because prenatal diagnosis. So we have prenatal diagnosis from the last 30 years, improving with the ultrasounds and detecting every time more efficiently malformations, most of them surgical malformations that we know very well as a neonatal surgeons, and we need to face postnatally with these malformations many times. And now we have the option to detect very early in pregnancy. So that makes sense that we have this possibility, and knowing the natural history of many of these conditions. So we don't want these babies in utero to be dying or to be progressively worsening. So that makes sense that we can do something as early as possible in the intrauterine life to do some kind of corrections. These corrections, this surgery is not always to fix the problem. Sometimes yes, okay, you will see like a twin-to-twin transfusion syndrome in between twins, so we can treat the cause and we can fix the problem, but most of the times it's try to improve the situation. So we can provide a better neonate for us to completely fix later on, but the idea is to change the natural history, to improve the outcome and the prognosis in these babies. So as I said, we have very good prenatal diagnosis tools. So of course, the first one is the conventional sonography, that we can detect most of the malformations at the 20 weeks ultrasonography usually. We can do 3D visualization of the surface and also 4D, so we can analyze movement of these babies. This is an SPINA BIFIDA fetus with, we are analyzing the movement of the legs and the feet. And also we have possibility to do Dopplers, so we can analyze the hemodynamic status and the flows of many vessels in the fetus. Also diagnose in the heart many of the malformations with the echocardiography. Of course, fetal MRI will be a good complement to that. So a fetal MRI is very good for chest, abdomen, and mostly for the central nervous system. So we can have a very good approach of the brain. So with all these tools, finally, we will have a pretty good diagnosis of a fetal malformation. And we know many of that will be lethal, okay, during the fetal life or even later. But others are not lethal, but we will have a very severe disabilities and problems for the life of these kids. So for that reason, we can, after detection, do different strategies. One of that is after some of the malformations are detected, just follow the pregnancy and be ready for the neonatal period. For instance, you can see an esophageal atresia, okay, can be detected in utero. This is an MRI, so you can see the distended pouch here, okay, and also no stomach. So then, with that, we can be ready for this esophageal atresia postnatally. Sometimes we can move the time of the delivery. For instance, I had very good experience moving the deliveries a little bit early, electively, okay, not for spontaneous delivery, but electively delivering at 34 weeks for gastroschisis allows me to have better babies with better bowel and better results. And finally, we will talk about the perinatal treatment, the fetal surgery itself, is doing something before baby is birth. So basically in order of invasion, so we can put drains or shunts, okay, by ultrasound guided percutaneous access, okay. We can do minimal invasive fetal surgery, that is fetoscopy, okay, with very small scopes we can introduce different instruments or laser fibers to do surgeries. And then finally, we can do the open fetal surgery. So that means that we need to open the uterus, expose baby, operate the baby, and then close everything. And finally, we can do E.X.I.T procedure. That is a procedure very similar to open fetal surgery, but at the time of the delivery. Okay, so once we fix the problem, we can clamp the cord and deliver the baby. So this is all general things. So we know that the fetal surgery is an evolution from the adult surgery that provided tools for the pediatric surgery, finally more specific small instruments for the neonatal surgery, and now we can move to the fetal surgery. And still we don't have specific instruments. We need to use neonatal surgery instruments for laparoscopy, for other applications, so we are working off-label in most of the cases. So as you know, the father or the Pope of the fetal surgery is Michael Harrison. He, many years ago, 35 years ago, started to work with animals and then started a clinical program in San Francisco, and he stamped the name of fetus as a patient. So everybody in this field, we have good relationship with him as a friend and as a mentor, and still these days I am in touch with him and always very, very wise advices. So he learned everybody that we need to test everything in animal models. And the best animal model for fetal surgery is the fetal sheep, probably, besides the monkeys, because the size of the animals are very similar to human. So the gestation is pretty long, it's half of us, and that allows to use instrumentation and to test all the malformations that we want in this kind of animals. So this is the research institute in Barcelona when I was starting all these experiments, and the OR that we are using, this is the OR we are using here at Cincinnati Children's, still working with animals, large animals like the fetal sheep. This is our lab now here in Cincinnati. So we are many members working hard in this field, and I will tell you that we are still mostly working in CDH, in SPINA bifida and gastroschisis, and spending a lot of time in these projects using stem cells right now and trying to regenerate some of these defects. We will talk later on about that. So the idea of our lab is to do basic research, of course, but mostly try to do translational research. So very quickly, we can go to the clinical application and then do the jump from the animal to the human as far as possible. And then we can apply all this innovation and all these surgeries to the human fetus, but that should be done in a very structural and very well-coordinated fetal surgery program. In my opinion, should be a co-directed program, okay, with two legs, the obstetricians and the pediatric surgeons, because many places like Europe, the MFMs, maternal fetal medicines, obstetricians are leading these programs. Other places like USA is the pediatric surgeon leading these programs. I think both parts are very important, and we need to co-lead these programs to be more consistent, more comprehensive. And then, of course, it's a multidisciplinary program. There are many disciplines that needs to help to push in these programs. If not, it's really, really very difficult. So mostly neonatology, radiology, anesthesia, all are very important subspecialties that needs to be involved in the development of these centers. This is a good explanation in this publication of all the components that should be trained and having experience to create a very good fetal program in any center in the world. Then it's also very important not only to do operations, also to orientate families. So the counseling is really, really important in these surgical malformations. So there are some malformations is very easy. In one meeting, in 1 hour, we can explain the families what are the options and what are the follow-up. But there are other more complicated, so we try to divide in 3 phases. So for instance, for CDH or for SPINA bifida, we do phase 1, showing the families all the prenatal imaging, fetal MRI, ultrasounds, etc. We do an assessment with a genetic counselor, and after that, answering all the questions, we talk about options and possibilities of fetal surgery if it's indicated. Then, if that is the situation, we do a phase 2 to meet with the family to talk specifically about pros and cons of fetal surgery, all the risks, all the benefits, and also after that, if there is a candidate for that, so we go for phase 3 that basically we can answer the last questions and do the consent reports. So talking about surgery, the most similar surgery to neonatal surgery is open fetal surgery, because we have in our hands the patient, we have in our hands the fetus, so we can operate very similar we do in a preemie. So for instance, this is an image of spina bifida. So you can see we can touch actually the cyst of the spina bifida. This is the back of the fetus, and this is the uterus that is exposed, okay, after opening the mom. And this is the staples that we use to avoid bleeding and to maintain open the uterus and the membranes. So as you see, it's like having a baby in the table of the operating room. But there are some limitations of open fetal surgery, as you can understand. So opening the myometrium makes that the dynamics can start. So even we use very important tocolytics to maintain the uterus quiet. Sometimes there's rupture of membranes, a labor, and then a few days after the surgery, we can lose a baby that was perfectly well operated. So everybody in this field are looking for minimally invasive surgery strategies in fetal, and fetoscopy is the way. So with the small instruments, okay, they're very, very tiny optics, like we can use scopes of 1 millimeter, 2 millimeters, and very tiny sheets to be introduced in the womb, and that will minimize the invasion on the uterus. So also we can have a very good image of the fetus and all the membranes and all the placenta with this kind of scopes. So for instance, this is a 2-inch station. So we are inside the uterus, so you can see very well the hand. We can access to the face, okay, it's lips, nose, so we can do intubation in these babies for tracheal occlusion. Also, we can see the structure. So this is the umbilical cord. Okay, this is the insertion in the placenta. Okay, and also in the placenta we can follow all the vessels and also see the co-twin in the other side of the membranes. So, but that's not perfect. So still we are creating a hole in the membranes. Okay, this hole don't heal, and then sometimes can detach the membranes or can produce a premature rupture of membranes anyway, less than open, of course, but still a problem. So we need to fix that in the future. We need to use some kind of sealants, some kind of strategies to avoid that, because sometimes we also have prematurity because of that. So all this is a list of conditions that we can offer fetal surgery. Okay, all these in purple are still on investigation, but soon will be implemented. So we talk about different strategies or different approaches. Still we use open fetal surgery to treat solid CPAMs, to treat sacrocolchical teratoma, and also for spina bifida. We will talk a little bit about that. So talking about CPAMs or cystic lesions in the lung is really easy to detect that, looking some kind of bubbles in the lung of these fetuses by the ultrasound. And that is not a problem. The problem is when we see a baby with a solid mass, mostly, and that are growing very fast and compressing the other structures in the chest, not only the lung that can produce secondary pulmonary hypoplasia, also the mediastinum. So the mediastinal shifting, compression of the heart can be very severe and then can produce hydrops, okay? When the fetus starts with hydrops, we are in a bad situation. You can see here fluid in the belly, ascites, is the liver, the bowel here floating. You can see pleural effusion, also edema. Very huge edema here in the scalp and all the skin. So it's an anasarca. So these hydros fetalis will finish in fetal demise very soon. Okay, this is a necropsy of a mass in the lungs for a solid CPAM. So how to prevent this? So there is a ratio, an index that's a CBR, okay? CBR is the CCAM volume ratio. It's calculated using the formula of the ellipse, and then calculating this formula, okay, by the ultrasound, we can anticipate if this baby will have hydrops or not. So anything lower than 1.6, we are in the safe zone, okay? More than 1.6 in the CBR, we are starting having risk, and very high risk to develop hydrops. What happens if the baby develops hydrops? So if we have hydrops, we see that if without treatment, we lost almost 100% of fetuses. Without hydrops, almost 100% will survive. So it's the totally contrary situation. So hydrops is very important to detect. So the first thing we need to do when we detect a CBR more than 1.6 with or without hydrops is to start with maternal steroids, okay? That's the new trend now to avoid rapid growth of these masses. So with only this in one round or in the next week, a second round, we can arrest the growth of this mass and avoid problems. So for instance, this case that we did with a CBR of 3.4, okay? So after 8 weeks post-steroids, the CBR was 0.8, so more than safe. So pretty good results. So we know that 50–60% of cases, this steroid therapy will work in these solid masses, so that's very good. If not, we will need to go for fetal surgery. So this is the algorithm after that, the steroids, okay? So of course, if there are associated anomalies, okay, we need to counsel about this severity, right? But if we have non-anomalies associated without fetal hydrops, we can follow the pregnancy and do postnatal treatment, of course. But the problem is when we have a CBR very high to fetal hydrops, we do the steroids, and if it's not, they are not working, so it depends. So if it's late than 28 weeks, 30 weeks, we can do an early delivery and operate the baby. But if it's earlier up to that, then we have to do fetal surgery, okay? What kind of fetal surgery? So it depends. If it's a solid mass, we need to do a lobectomy in the fetus. If it's a predominant cyst, we can do a thoracoamniotic shunt. So this is an example of a cystoamniotic shunt. So we can put this double pigtail, this is very small, okay, by percutaneous access, okay, ultrasound guidance inside the cyst, so we can drain to the amniotic fluid this mass, okay? And this is an example of fetal lobectomy, okay? So we can expose the uterus, open uterus, take out the hand and the side of the baby and do a thoracotomy to remove the mass, okay? Once the mass is outside, we close the baby, we replace baby inside the uterus and follow the pregnancy. Okay, that's for lung lesions, but also sacrococcygeal teratoma, SCT can be a problematic thing in a baby. Sometimes they are small and there is not a problem, okay? And you know that there is origin in the Hansen's node in the coccyx that produce the 3 layers, germinal layers, producing these teratomas, okay? There's many tissues there, as you know, and can be mature in the most of the cases. So one thing we need to look in the ultrasound in the prenatal diagnosis is the component. If it's fluid, if it's solid, or if it's mixed. Solid are worse because they are growing very fast. Mostly when the vascularization is very, very important in these masses. So we know that the feeding vessels are from the arteries, from the medial sacral artery and the internal iliac arteries. So also we can determine the type of mass, if it's more external or more internal in the body. So we can use the actual classification of Allman of type 1, 2, 3, or 4, depending if it's more external or not. This is an example of a small external one. This is a more medium size. And this is a huge, large, even with rupture skin, okay, rupture CST that can produce a lot of problems. So basically the problems in utero is this big mass is still in blood, so the heart of the fetus needs to pump for this big mass, okay? So the height output makes the heart to go to cardiac failure. And finally, again, hydros fetalis and fetal demise, okay? So this is a fetus with fetal demise, totally hydropic, okay? Because the heart was pumping to this big mass. So again, we need to stop that in a good moment. And there are different prognostic factors that will indicate us that this is a bad case. So basically, we need to analyze the growth rate, how big is the size growing, the solid component, okay? We can do the ratio in between the tumor volume and the fetal weight of the baby. And it's very important to do echocardiography. We need to assess the heart of this fetus and look for the combined cardiac output. If this is more than 500-600, so we know the baby is struggling, and then we need to do something earlier than later to avoid the fetal demise. It's an example of open fetal surgery. So opening the uterus, we expose the lower part of the baby so we can operate this mass. Basically, we need to do a very quick surgery. It's a debulking. We don't need to resect the coccyx or any detailed thing. It's only reduce the mass. Okay, so we can use different vessel sealing devices or staples to go faster. Okay, this is a staple removing this big mass, okay, from the baby and replacing baby inside. Okay, that's open fetal surgery for CSCT. And the other condition that we use open fetal surgery is SPINA bifida. Okay, so in SPINA bifida, as you know, this is the typical neonate with the lesion in the back. So the exposed spinal cord is the problem. All right, it's very common, and the problem starts early in gestation. After 4 weeks of gestation, in the embryo, there is the normal process of the primitive neural tube to close and neurolate, and this is the normal thing. But if this is not happening, we have an exposed spina bifida. So we have an open spinal cord like a book, okay? This is the normal, this is the open, exposed. That the problem is the supplementary hit, okay? That this is this malformation, but it's not as bad. The problem is later, the second hit, when the amniotic fluid is progressively damaging, making trouble, killing neurons in this spinal cord. And that is demonstrated in animal models that there is a progressive damage in utero, mostly at the end of the pregnancy. So you can see this baby at term with this all neuroinflammation, this meconial staining here. So it's too late to recover this. I did several studies in animals. So this is a retinoic acid model in the mice. So you can see the spinal cord is more or less preserved, and later in gestation is totally destroyed. And even in the cellular way, so in rats, also here in Cincinnati, we are doing this. So this is the normal skin, okay? And this is the placoat, okay? The neural tissue exposed outside. So we can demonstrate a lot of microglia, activated microglia, actually, astrocytes. So these are astrogliosis that reflects the important neuroinflammation and neuronal loss that we have here. So you can see here in the other sagittal, there is a lot of green, it's microglia. And this microglia usually is resident there in this shape, like stars, but when it's inflamed, it's activated, it's round, like here. So it's activated microglia, also apoptosis and neuronal loss. So that's the problem of the amniotic fluid over the spinal cord, right? So it's direct damage of this fluid. The other problem is we have leakage from the brain, okay? All the CSF is going out. That produced the Chiari malformation, herniation of the cerebellum, and finally, obstruction and hydrocephalus. So makes sense that as early as possible, we put a barrier here, like a watertight barrier, so we can avoid the problem of the two fluids. And that's the rationale of open fetal surgery. So for that reason, and in USA, in 2003, they started actually 3 centers, the MOMS trial, trying to check this repair in utero of the spina bifida, doing the same procedure we do in neonates, comparing with another group postnatal, what's going on with these babies, if it's a benefit or not. So the final results in 2011 in the New England Journal demonstrated benefit for these babies. So basically the benefit is we reduce at half the need for shunting for hydrocephalus. We improve and the score of mental development and motor outcomes, we can completely revert the Chiari malformation, and also not only the improved ambulation of these babies, now in the moms too, with these older babies in this cohort, is recently demonstrated urological benefits. So all these are benefits for babies, but of course, there are some risk, and it's mostly for moms and for the fetus, mostly in terms of prematurity. Okay, so preterm delivery is basically 80% of cases with open fetal surgery, and the overall is 34 weeks at delivery. And there are other problems that can happen on these cases of open fetal surgery, mostly rupture of the uterus in moms, because there is a scar in the uterus, of course. This is an example of a primary repair in the back of a fetus with SPINA bifida, and sometimes it's not possible. We need to put an alloderm patch to cover these lesions. And this is baby delivering with the primary repair. This is another with a patch that usually goes away after 6-7 weeks, and there is a nice epithelialization behind. So we can demonstrate that with this surgery, in our cases, most of them recover the Chiari, okay? So this fluid around, again, the cerebellum, and we decrease at half or more the needs of shunt. But still the problem, as I said before, is the prematurity. So we don't want that. So how to fix or improve that? So I started to work many years ago in Barcelona, and now here in Cincinnati, trying to implement minimal invasive fetal endoscopic surgery for this repair. Okay, so I started with the animal models with the sheep, creating this defect. As you can see, this is the spinal cord exposed, the CSF going out. Okay, and then after that, 3 weeks later, going to by endoscopy to try to fix the problem. So I used different patches, different glues with the strategy to fix that. And you can see here, this is a lamp without repair. Okay. And then this is a lamp after repair. Okay, you can see the histology here: destroyed spinal cord, protected spinal cord with the patch, and the repair. So that's the rationale. So we did many publications in that years, okay, until even we can approach that with only one trocar, okay? So what I say is a safe method. It's feasible in these animals, okay? But what we are doing right now is not only one trocar, it's more complicated. If we want to implement a suture, we are doing 3 mini trocars. So we are doing 3 millimeter and 2 millimeter trocars, actually 3. That's the disposition we are doing. We are exposing the uterus. We are doing a camera of heated and warmed and humidified CO2 to maintain the baby like in a sauna, okay, and then do the repair. So this position in the uterus, as you see, it's minimal size, 3 millimeters, 2 millimeters for the left hand. And we are using also B-lock system, barbed sutures to avoid knots inside. And then, of course, minimal small instruments to accomplish these repairs, okay? This is the suture in the skin at the end. And also we can put patches with running sutures without difficulties. So we did 40 cases, actually. This is from the last year, okay? And we did myelocele, myeloschisis, and myelomeningocele, okay? This is, again, the disposition of the 3 cannulas. We put anesthesia in the intramuscular in the fetus before starting any procedure in the baby. And we have very good view of the placode. So magnification allows us to do a very good release of the placode, right? And then you can see here, this is before this cystic lesion, okay? So how the placode is totally free, and we can see even the vascularization of the neural tissue. After our neurosurgeon is totally happy, we are happy with this release of the placode. We put rolled coiled patches. Okay, actually we are using 2 to cover the dural canal and dural repair. So it's 1 and 2 here. Okay, and then finally we run the skin. Okay, with these barbed sutures, we can close the primary defect. You can see different closures we are doing right now. And that's the previous case with the patch after the placode is released, and this is the closer perfectly well. The advantage to have the uterus exposed is we can close the hole after remove the cannula, so we can prevent membrane opening, so we can pass these needles and close the membranes inside and outside. This is baby is delivering, okay, with a pretty good closure. We didn't have any day sense in the 40 cases, so pretty watertight in all cases. And if I have time, I can show you a little video. It's double speed, so we are quick, but not as much. So this is the location of the placenta. So we determine the position of the trocars by Seldinger. We introduce these cannulas. We fix the cannula like in a neonate to avoid dislodgement. Then inside, we can put the warm, okay, CO2, also humidification, and then you can see fetus there. So we can control under visualization the introduction of the other cannulas. At same, we do fixation. This is the 3 cannulas, the ultrasound control of the baby, so we can work inside. So this case was a malocil, okay? This is the anesthesia for baby. Sometimes we put a stitch in the back to hold the baby and avoid the fluid bothering us. We use cauterization, very minimal, trying to avoid bleeding, and then we do a very precise release of the placoat and the roots. You can see here all the roots. It's totally free, okay, no tethered. And then we create the pockets underneath the skin to do the skin flaps laterally. And then once we have a good lateral release, we make measurements of the patches. So we pass the patch, coil it inside the cannula, and then with these little stitches, we can fix to the fascia these patches. And then finally, once we do these loops, okay, and attach the patch, we can run the skin, okay? So do the same, we close the loop, and then run the barbed suture around the skin, so we can have complete skin closure at the end of the procedure. As I said before, we can close the holes, okay, with this control and the skin closure. All right, so that's for spina bifida, and this is what we are doing now. There are other procedures that are not open fetal surgery, and basically is the E.X.I.T procedure that we do at the time of the delivery, okay? So usually we do for congenital obstruction of the airways and also for masses that are compressing the trachea, right? So we did many cases, these are all the indications, so have experience in many cases, and now, so the classical 1 hour we have for E.X.I.T, maintaining the oxygenation through the placenta and the umbilical cord for baby. So we can have 3 hours even. So we did mediastinal tumors resections even for 3 hours on E.X.I.T. But you need to do a very good E.X.I.T. So for that reason, it's not a C-section. So you need to put anesthesia in the fetus, okay? So this cocktail that we did before for spina bifida, okay? And also you need to maintain the mother very stable, not bleeding, and also the uterine relaxation is mandatory. So you can use halogenated gases, you can use nitroglycerin, etc., because you need to maintain that relaxation. It's not the situation in a C-section that you have contractions. This is a case of a cervical teratoma. This is the mom, okay? This is the head of the baby. So our neonatologist was trying to intubate this baby. It was impossible because the mass was compressing. So we used a wire and a rigid laryngoscope and rigid bronchoscope was not possible. So finally we decided to start the operation on placental support. So we did partially the dissection of this teratoma until we had the trachea in our visualization. Then we decided to intubate after decompression was possible. So we closed very, very quickly the skin, and we went to the other next door operation room to finish the E.X.I.T procedure. So then in the other OR, we completed the resection. That was a mature teratoma. So that's the goal. This is an epignathus. You can see the big magnitude. So we decided not to touch this and went straight to the free area of the neck for a tracheostomy, okay? So this is another case I did in Barcelona. So this is the prenatal diagnosis, totally blocked the mouth, okay? You can see here the nose and the mouth were completely blocked. So we went straight on E.X.I.T to the trachea, we cannulated the trachea, ventilate baby, and then clamp the cord, okay? So baby was transferred in this case to the NICU for some hours. We completed the study. This is the mass. And finally, with a secure airway, okay, we did the resection of this mature teratoma epignathus in a safe way. This is the baby before and after, okay? So going home at 10 days of life, and this is the baby controlled in my clinic some years after. Other indications are not as common as tumor masses in the neck is microretrognathia. So sometimes it's very, very, very small jaw and the tongue is protruding back. So it's not it's safe to have a neonate with this, with difficult intubation. So usually we can do tracheostomy on exit for doing jaw distraction later on. So this is another option, that is the congenital high airway obstruction syndrome, the chaos. Okay, you can see congenitally is blocked, the larynx, okay? So the fluid that the lung is producing is totally retained, creating this hyperplasia and these huge, huge lungs, ascites and problems for this baby. So the option is to do an exit procedure, okay, to cannulate the trachea. Even we are now recommending fetoscopy to try to open this breach, okay, if it's possible, before exit. Okay, so this is one of the demises with these big lungs. As you can see, this is a neonate with the tracheostomy. It's a baby with the tracheostomy after the Cowes syndrome. So that's for exit procedure, okay? So there is another minimal invasive surgeries that we can do many things, putting needles or putting instruments with the ultrasound-guided percutaneous access. For instance, cardiac surgery. So we can do valvuloplasties in fetuses, okay, when it's required, okay? So for instance, in critical aorticopulmonary valve stenosis, we can do some fetal procedures, okay? The idea is to go from outside with a needle, go through the uterus, through the chest of the baby, inside the ventricle, in this case the left ventricle, and then put a balloon in the stenotic aortic valve, okay? So that can be performed, okay, with this needle, okay, with the ultrasound, so we can navigate. You can see here inside the uterus. Okay, this is a case from Barcelona. So we enter in the chest of the baby with this sharp instrument. This is the distended left ventricle. So we can go from the apex inside and then access the stenotic valve here. Okay, so pass the catheter and do ballooning for dilatation. And then finally, we will talk about fetoscopy. That probably is the most useful tool in fetal surgery. So basically, we use fetoscopy for twins, okay? So there's monochorionic twins that share a placenta, they can have different problems. Basically, what we say twin-to-twin transfusion syndrome, okay? It's another condition, is TAPS, is similar. And also when one of the fetuses, the twins are acardic, so there's the trap sequence. You will see that this acardic is like a teratoma, so the healthy baby is pumping to the acardic twin, making trouble. So what about twin-to-twin, all right? Twin-to-twin is the connection in between the two umbilical cords insertion in the placenta that all the babies sharing placenta having this. So if you have a balanced situation, so one baby is passing blood to the other and the other to the other, it's not a problem. So this is normal. This is physiological in monochorionic. But the problem is once one baby is given more than the other, okay? So if it's not balanced situation, one is the donor, and then this donor is becoming dehydrated, okay? And starts to save urine. So not urinating, creating less amniotic fluid in the sac, okay? So it becomes totally stuck, okay? The other baby is the contrary, receiving a lot of blood, making a big bladder, peeing a lot, and then even having problems with the heart pumping so hard, right? So this is the problem of twin-to-twin, and we can detect that looking at discordance of fluid, okay? So here you can see the stuck twin, no fluid around, lot of fluids in the recipient, okay? So once we have less than 2 centimeters in the one of the babies, more than 8 in the other, this discordance of fluid makes stage 1. Stage 2 is when the small baby is even having the bladder totally empty. Stage 3 is when one of the babies having abnormal Dopplers, so they are in trouble hemodynamically. And finally, if one of the babies is hydropic, it's stage 4. One of the babies is dead, it's stage 5. Okay, too late. So what we can do? So we can put the scope, the fetoscope with the laser, and then try to identify every single connection in the placenta, okay? So you can see here these connections in the placenta. So with the laser, we can activate energy and burn, photocoagulate these connections. So of course, you need to be very selective and identify all the connections and don't miss any, okay? And you can be very, very aggressive, because if you are burning something is not necessary, you are limiting placenta for this baby.
Twin-twin transfusion
You can hear
syndrome,
this maybe?
or TTTS, is a rare but serious condition that can affect the well-being of identical twins and triplets that share a single placenta. Severe TTTS may cause fetal injury and fetal death or loss of the entire pregnancy. One of the treatment options for TTTS is fetoscopic laser photocoagulation. When you look closely, you will find different kinds of blood vessels linking one twin to the other. It is believed that when blood flow through these connecting vessels becomes imbalanced, TTTS occurs. Local anesthetics are injected, and a small incision is made before a fetoscope is inserted into the amniotic sac of the recipient twin under ultrasound guidance. The fetoscope is then used to examine the surface of the placenta. All of the blood vessels that connect the twins are carefully mapped out. Next, laser is used to photocoagulate or burn the connecting vessel until it is occluded. We then move to the next connecting vessel and repeat the laser therapy. Each of the connecting vessels are sequentially treated with the laser until they are completely occluded. We then re-examine the placenta and repeat the laser therapy as needed to ensure all of the connecting vessels are completely occluded. We reduce the amniotic fluid in the recipient sac to normal level. Antibiotics are given into the sac and the fetoscope is removed. The incision is then closed and the pregnancies continue with careful monitoring of the twins.
So you saw that. So that's the technique, okay, summarizing in a very cool 3D animation. And this is our results. So we have done more than 1,000 interventions for TTTS in our center, and our results are pretty good. So we can get an overall 84% survival in both groups, even in the advanced stages, and at least one baby, 92% of the cases will be alive for these families. So the goal of this surgery basically is to get a couple of babies, healthy babies. Okay, other indications of fetoscopy will be amniotic bands. Sometimes we can detect amniotic bands that can amputate completely one extremity, all right? So I developed this model in Barcelona like 15 years ago, and then we created amputations in these lamps, okay? So the idea was to avoid that by surgery. So using the laser and cutting the point of constriction, so we were able to do that. And then very quickly, we moved to the human clinic to try to apply this, this technology. So we jumped from the animal to the human, and then we had this case, okay, that was an amniotic band involving the umbilical cord and the left leg. Okay, you can see here the edema, okay, distally to the amniotic band, all right, and the cord here next to that. So we did with laser the release with one port of that. I will show you later. So in Cincinnati, finally, we did 46 evaluations of amniotic bands. We did operation fetal intervention in 21, and then mostly we did the surgery around 23 weeks of gestation. Basically, we do the same with the laser, but also we can use other microdissection Jaspers in part of the cases, or both instruments and laser in the cases. So we can use also 1 or 2 ports. And our survival to discharge is 94%, so pretty good. Other technique that we can use is to do cystoscopy. So when you have posterior lateral valves and very large bladders, you can go inside the fetal bladder and do some surgeries. Here you can see the diagnosis of posterior lateral valves. So this is an ultrasound with the keyhole sign. So this is the posterior urethra, totally distended, and this is an MRI. So you can see how big is this bladder pushing up the lungs, okay? And this is the posterior urethra distended. So these babies usually will have problems with pulmonary hypoplasia. So to drain this fluid outside, you can put a shunt, but also you can put the scope, okay? So this is the shunt that we can do, double pigtail, but in many cases, we prefer to put the camera, do the diagnosis, okay? And then finally, try to ablate with the laser these valves, mostly if the kidneys are having a good function. So at that point, we need to be very cautelous because sometimes the angulation don't allow you to be safe putting the laser like this case, okay? So you can perforate the valves and be patent on the urethra so baby can pee. But if it's not possible, you can also put a transurethral catheter, this double J, that you can go through the penis outside to the amniotic cavity. And finally, congenital diaphragmatic hernia, okay? Putting a balloon in the trachea will be very helpful for these babies, as you will see. So you know what is a congenital diaphragmatic hernia. You know that there's different degrees of severity, different degrees of liver herniation. And then, so what happens is a stop in the normal development of the lung in a very early gestation. So there will be a degree, of course, of severity. So depending on the severity of the pulmonary hypoplasia, even you are in the best hospital in the world, even you have all the possibilities for treatment, you will have babies that don't make it. You will have fetal and neonatal death. So for that reason, the only chance for these severe category babies is to induce lung growth when the babies don't need the lung, okay, when they are in the fetal life. So how we can do that? So the way we found out is that plugging the trachea, so retaining the fluid the lung is producing, we can induce lung growth. Of course, not in a normal range, but we can improve the situation. So we did in Barcelona, also in Cincinnati, a lot of stuff in collecting amniotic intrapulmonary fluid from these occluded tracheas in these lamps, and we did proteomic analysis. So we found tons of proteins and growth factors that are key for development of the lung. So this fluid is really important to be there, okay? And mostly all the growth factors in the proteins are factors that are inducing cell proliferation and maturation of the lung. So that's really, really important to have this fluid in place. So the other question is how we can detect these more severe cases. So basically with prenatal ultrasound and fetal MRI. So we know that by the tracing mostly, okay, we can calculate the area of the contralateral lung, okay, in the 4 chambers ultrasound, and then calculate the lung-head ratio, calculating the head circumference and the lung in the contralateral side, but most accurately the observed expected lung-head ratio, so we can do in any gestational age that you want. So this is observed to the expected lung-head ratio, okay, will mark the category of this fetus. So we can find mild or moderate category, but also we can have very bad cases like severe or extremely severe cases. Mostly when the observed to expected lung-head ratio is less than 25%, okay? And then if also there is up in the chest, the survival is very, very low, up to the 10%. That's the candidates for fetal surgery, for tracheal occlusion, and potentially this also can be also good candidates. So that's the European trial using tracheal occlusion by percutaneous insertion of the fetoscope and access the glottis and the trachea. Okay, this is the fancy pictures we did here in Cincinnati to do this the same treatment. So we can place this balloon in the trachea and then after that retain the fluid that these lungs are producing. This is the balloon. It's a French company. It's very tiny, 7 millimeters diameter. And of course, to put the balloon, you need a very good position of the fetus, okay? As you can understand, if it's in a bad position, it will be very difficult. This is the balloon going inside the trachea. You can see the rings, okay? And this balloon is inflated, okay, under visualization. And then we can go through the balloon to see the carina on the other side and then plug the detach the catheter for tracheal occlusion. So we know that the survival in the European previous trials was going from 8% to 55% of survival, at least in Europe. We don't know here in USA because we have a baseline survival of 40% in the worst cases. But so far, with the cases we did in Cincinnati, the tracheal occlusions we did in this category, we increased the survival to 80% so far, but of course, very small number of cases. So the goal of this therapy is not to obtain normal lungs, it's to obtain better lungs, okay? To decrease the severity of the case and try to avoid ECMO, try to avoid high frequency. This is the numbers of the studies we published in Europe, okay, having 54% survival in the left side, 40% survival in the right, and also, most importantly, decreasing morbidity in these neonates. This is the randomized trial Rodrigo Ruano did in Brazil, and he had the same numbers, okay, increasing almost 10-fold the survival in these babies. So right now, it's almost finishing the severe total trial. The moderate category is already completed, so we are waiting for the publication, and looks like for efficacy, they stopped recently the total trial where we are participating. So they included some years ago few centers in Europe after FDA approved the balloon, and Cincinnati is one of that centers that are participating in this trial. So, and I finished, I think I was talking a lot, and my final input will be about the future for fetal surgery. So I can anticipate that all fetal anomalies will be included in the treatment. Fetoscopy will be probably the best approach that will be implemented with new technologies, of course. And of course, stem cell therapy and tissue engineering will be a very important addition to fetal surgery. That's why we are working in my lab very hard on this particular thing. So we are trying to implement stem cells that we can, fetal stem cells that we can get from the amniotic fluid or from the baby. So these fetal mesenchymal amniotic cells can produce different tissues to replace organs in the baby. And also we are working very hard in neural progenitor cells to try to regenerate the damage in the spina bifida in these babies. Well, you see there is a lot of things done. There's a lot of things to do in the future, long road to go. I am a fan of international collaboration. I think everybody needs to put their part. There are very talented people worldwide that we need to work together and collaborate, not be close. So for that reason, I opened my center here in Cincinnati to everybody that wants to come visit here or do research or whatever. So that's the goal, to make better the life of these little babies. Thank you so much. I'm happy to take questions.
Well, Jose, thank you very much for this great presentation. We enjoyed it a lot. I'm sure there will be questions. So I ask for the participants to raise their hands to ask questions. Okay, Munter would like to ask questions. Okay, Munter, we are listening.
Yeah, thank you very much. That's fascinating, and thank you for delivering such a fantastic lecture. There are two questions. One is, why is the discrepancy in between Europe and the USA regarding the outcome of these, from 8 to sort of 55 and then 40 to 80? Mm-hmm. This is my first question. The other question is a futuristic question, which is, where are we in achieving tissue engineering of an artificial womb, an artificial uterus?
Okay, so Muntar, thank you so much. I'm very glad you are here. and very good question. So first, the first question is something that I was wondering many times, coming from Europe to USA. So I am like a hybrid person now. So finally, I understand that. So besides the quality of the neonatology, the technology we have here, So I think the main difference probably is the ECMO. So here they are believers on ECMO. In Europe, we don't believe on ECMO. So every time in Barcelona, I had to put a baby on ECMO, I say, oh my God, this baby will die. So my results in ECMO of CDH in Barcelona survival was like 10% only. So of course, I did a lot of more efforts in the regular ventilators, oscillators, etc. But here, people are very committed with ECMO. And so right now, today I have 3 babies on ECMO with CDH and very severe categories that had not the balloon. So really, many of them don't make it, but many of them do. So we have a 60, 70% survival on ECMO. So I think that's the main difference. So I am becoming a believer on the ECMO, but I also becoming a believer on the tracheal occlusion to avoid the ECMO. So because I don't like these babies, like 3-4 weeks on ECMO with all the sequelae. So of course, you can get better results in survival, but a lot of morbidity. These babies can stay in the hospital for 8 months, 10 months, tracheostomy, Nissen, you know. So yeah, that's probably the main explanation about that. Second, the question about the tissue engineering. So I think it's an developing field, and probably more than create a uterus. Okay, you know, Alan Flake is making a lot of advances on the placental artificial placenta, but in terms of tissue engineering, I would say more probably cell therapy. So create like selective cells to recreate organs, okay, and to fix the problems that from the factory are coming back. So it's not only degeneration, okay, like any or traumatic things. Also, I think the congenital malformations can be fixed, and it's a very natural way because the fetus is a pure stem cell in evolution. So we can learn many things from the fetus and try to use their own cells to implement in the wrong areas of the fetus. So I think more than tissue engineering. That's
so. You mean stem cell thing is better? You believe in that better than any other tissue engineering?
Yes, stem cells, and also probably exosomes or whatever is stem cells regulating the paracrine effect in the environment of the injured area. So I think that can fix better probably locally. Yeah, but of course sometimes you need to replace organs, and then tissue engineering is amazing. Yeah.
Can I just ask another question? What is the incidence of miscarriage post fetoscopy or fetal surgery?
Well,
because a lot of mothers are worried about that if you discuss this with them.
Depending on the technique you are using or the condition you are doing. So for instance, you are doing an open fetal surgery for a hydropic baby with a mass, saprophytic teratoma, so that will be 50%. So it's very risky babies. In other conditions like SPINA BIFIDA or CDH, whatever, it's very, very low. So probably it's 5-7% of cases. Basically because prematurity. So these babies are very premature and a little bit sick, so they don't make it. But during the surgery, it's very rare to have a fetal demise intraoperatively, very rare.
Well, thank you very much. That's fascinating. I usually enjoy your talks, and hopefully we'll meet in person in Braga sometime.
Hopefully.
And thank you, Monter. It was really very nice to have you with us.
Oh, thank you. Thank you, Aiden.
Okay.
Good to see you all.
Thank you. There is a question from Abdullah Zaruk. Yes, Abdullah, if you can hear us, you can unmute yourself and ask your question. Go ahead.
Hi, that was absolutely fantastic. An excellent summit, it really was. So I started to be interested in fetal surgery a while ago, Jose. We actually did a few cases when I was in the United States. Right now I'm in Qatar. And the learning curve after the mom's trial, we took a team and went to UCSF, San Francisco, and met the team. It was a whole team effort that went. It wasn't that extensive. It was just a few days. We went back, we met, we started a few cases, and the learning curve was so high. It was brutal and a lot of anxiety in trying to make this work. The question is, how do centers really start this? Because the expertise needed from the pediatric surgeon, from the MFM, from the adult anesthesiologist that's going to take care of mom, unless you take an entire team from elsewhere, it's very difficult. I mean, I ended up feeling uncomfortable to a degree that I took a mini sabbatical, and I spent 6 months at UCSF in California with, at the time, Han-Min Lee is there and still there, you know him well. An entire 6 months just to feel comfortable about how to set things up. This was after we even started. And so when I came here to Qatar, I got to tell you the truth. It was too much of a task and an enterprise to get it going for the region. So we still send our those particular babies that would benefit from those interventions away. So one question is, how is it, okay, I can get all the skills, I feel comfortable now, but how do you get that going so that you can transfer that knowledge? Yes. And the second part of it is, when you present your data, and the data I present is identical to yours, to the European maternal fetal medicine folks in France and England and so on, they disagree with the conclusion that something like tracheal occlusion is actually beneficial. And I'm fascinated by how these are prominent people, and I'm sure you've met them. I'm fascinated by how they argue, how they interpret the data to mean if it was a child in front of them, they would not offer it. So those two, I guess, philosophical questions would be great if you can comment on them.
Sure, thank you. Thank you for your questions, Abdullah. So yeah, so this is really tricky because there is nothing official to do education on fetal surgery. So yeah, it's about what you are doing. So visiting places, etc. So now in Cincinnati, we are having now like a mentorship program. So we are trying to mentor places in the world that really demonstrate that they are well organized, that they have the resources. Okay, and one of the things is create a team. Okay, so it's very common. One person say, "Oh, I'm very good. I have very good skills, so I can do these operations." Sure, but it's not about you. It's the whole team, as you say very well. So you need to have a very good MFM, very good anesthesiologist. If not, you are super bad. So then, once you create that, you need to be very patient. So create and build the program. So takes like 2 or 3 years, and then visit places. And mostly, you have a good link with one of the big centers. Is much better because you can have direct access for complicated cases, for mentoring. Now with telementoring is very good. So the example is we did with Argentina with Hospital Austral. So I went there to do the first 7, 8 cases of SPINA bifida with them. They started to do by themselves, very more confident. Now they have like 60 cases, right? So, and they are doing very well. So it's create a team and then link with a big center. And yeah, as you say, build your learning curve, right? So that's really, it's not as much as difficult as surgery. It's much as difficult to create or coordinate the team. Okay, control the egos. So sometimes it's not easy to have a very good balanced team. You know, there are many divas and things like that. You know, so to select very well your team. Okay, so you have good people, well trained, and with a good personality is key to have a good future in that way, okay? And then the second question was about the CDH. Yeah, well, I started my first balloon. I did in Barcelona with Jan de Press and Eduard Gratacos in 2002. It's 18 years ago. So it was one of the first cases in Europe. And from that, I was enjoying and suffering all these babies. So I know very well what is a baby that had balloon and what baby that had not the balloon. So I'm now dealing with these ECMO babies and I'm thinking why these babies are doing so bad, right? So of course you need to demonstrate with numbers, with the statistics, with everything that you have a benefit. That's why the total trial was done, right? Hopefully we have the results soon. But internally you have your feeling, okay? Yeah. And you see the pragmatic, the practical difference in between babies. Of course, sometimes one balloon can be bad or no responder or whatever, but in general, I think my impression about the tracheal occlusion is good. And probably in the future will be even better if we can optimize that.
Excellent, thank you.
Thank you.
Okay, thank you, Abdullah, for the question. And there's another question coming from our junior attending, Ergun. You know him, and
Yes.
he's interested and he's very into the fetal surgery, and hope he can be able to manage to come to your center and learn something and teach us something later then. So he
Sure.
has a question. Go ahead, Ergun.
I think you can hear me.
Yes.
Yes.
Thank you for this wonderful and promising lecture, Mr. Peiro. You've done a lot of marvelous jobs, and I think that will continue. So I have a question about decentralization. I mean, in the field of surgery, if we see one or two cases, yes, we want to do them, and we are just like, yeah, why cannot I do that? Why cannot do perform this surgery? So do you have a centralization policy, a governmental one or something else? And how can you manage to collect these cases in your center or the other centers?
Well, it's a good question. So actually, many countries, they have this kind of excellent centers of centralization. So they have one or two, and they can manage the whole country. I think it's convenient, mostly if you are working in public health. Okay, I'd recommend that. The problem is you are not in public health. So here in USA, the regulation is mostly the economic. So there's like a competition. So if there are some centers that compete very well, and they are the biggest ones, and there are others that don't compete, or they can beat that, and they need to go down and do other things, or just don't open a fetal surgery center. So there are many states in USA that they want to have their own fetal center. Okay. They try sometimes, they are successful, sometimes they are not. So basically here it's more about the big reference centers because you offer more experience, okay? So many complicated cases are referred from other smaller centers to you, okay? So that's the network. So we are a lot of fetal centers, and we are all joined in the NAFNet, it's the North American Fetal Therapy Network. And all together we try to collaborate, okay? But still there's some competition, okay? And in terms of other countries, like now I am helping like in Argentina, Peru, Dominican Republic, other places, Poland, whatever, Italy. I think need to be one big center in a big city, having a good population around, and allowing other areas of the country to have another one. I think in a medium-sized country, 2 or 3 centers make sense, and another centers that can do minimal things and refer the cases. So prenatal diagnosis should be very good, okay, with network in the country to provide the cases on time, okay, for these specialized centers on fetal surgery. But I agree with you. It's not a question of everybody wants to do, so it should be well done and very controlled, yeah.
Thank you.
No problem. All right.
There's a question from the audience, and it says that when you reviewed the last 20 years, is there any striking development in fetal surgery? If not, why?
So repeat the first part, sorry.
When you reviewed last 20 years,
Okay.
is there any striking development in fetal surgery?
Yes.
If not, why?
So, yeah, so I think there was a very quick development in the 30 years ago with Michael Harrison. Then it was like an establishment of fetal surgery. And there was a little bit years, like 15 years ago, a little bit more like a standby or plateau. And I think now we are again growing again. Okay, so I think once you can demonstrate some techniques are like standard of care, okay, like SPINA BIFIDA, like twin to twin, like urologic things. So then, and also you implement new things or new pathologies, so you are growing on that, okay? So we have a very high volume here. So we do like 4 to 5 fetal surgeries every week here. So, and we have every afternoon we have like 3, 4 to 5 cases, new cases, different pathologies. So I think it still is an expanding field. So I think it's growing.
Yeah, okay. Meltem would like to ask a question. Meltem also, she is a senior attending of our department. So Meltem, you can unmute yourself and ask your question. Go ahead.
Hello, Dr. Peiro. Thank you very much for your amazing talk. Very impressive, as always. My question is there any clinical application for the use of human amniotic cell-derived extracellular vesicles for lung development in CDH? And the second one is it possible to fill the tracheobronchial system with some kind of stem cells or growth factors before occluding the trachea? I'm sure that you have thought of this before. These are my questions.
Thank you. Thank you for the question. Yes, so the answer is yes. So we are working in the lab. We are collaborating with other labs. We are also collaborating with Augusto Sani in Toronto, with other partners. And that's a very exciting idea, to put something in the trachea after tracheal occlusion. So growth factors, exosomes, stem cells, whatever. So I think, yeah, but we need to understand first what's going on and what we need, right? It's not only to try that, also to explain the mechanisms why this is working or not working, right? So that takes time to do that. So, but I think yes, and also some medications, some drugs that are right now trying to be tested in animal models. So I think tracheal occlusion was a good implementation for CDH, but more to come with all these kind of strategies, sure.
Thank you very much.
No problem.
There is a question from Nizamettin Kılıç. Yes, Nizamettin, go ahead.
Yeah. Jose, first of all, I'd like to thank you. My name is Nizamettin from Bursa, Turkey. Is there a difference between fetal and postnatal surgeries in patients with meningomial cells in terms of the presence of the tethered cord? This is the first question. And second one is there a statistically significant difference in the lower urinary tract functions of the patients who treated in the prenatal period and postnatal period? Thank you.
Yes, so yeah, basically it's pretty similar in terms of the tethering the cord, but of course in the fetal life it's a baby's 23, 24 week gestation. Everything is very delicate and you need to be very careful for the spinal cord tissue, but you need to release completely because it's by definition a tethered cord. So you need to completely release and then cover watertight if you want to recover and to revert the Chiari malformation, okay? And also, the surgery is very similar to postnatal, so we need to release the placode. The only difference is sometimes you can recreate well the dura because the dura is very weak in the fetus. So we do in open fetal surgery, also we do fetoscopically. We believe on the patches. Another thing that you can do is a myofascial flap. So make flaps laterally and close the dura with the muscle and the fascia that many other centers are doing. So we can do that also, but because we have very good results with the patches, we don't want to increment more surgery on this small baby. So that is another option. And yeah, that's the main difference with the postnatal surgery. Yeah.
So what about the lower urinary tract functions?
Yes, so in the lower urinary tract, so the goal of the fetal surgery basically is to have a pulmonary survivor. So many times when we arrive for the kidneys are already done. So we can improve the kidneys, or we improve it minimally because the organogenesis of the kidneys are very early in gestation, and at the time we detect that 20 weeks, 18, 20, 21 weeks is late for the function of the kidneys. So we can decompress, of course, but we don't focus our attention on the kidneys. We go for postnatal peritoneal dialysis or transplant if it's necessary, or hopefully the kidney is good. But the goal of the fetal surgery is to replace the amniotic fluid, avoid the pulmonary hypoplasia, so we don't have this Potter sequence and the babies dying because they have no lungs. So then we need to replace the fluid by the fetal urine, making a diversion, right, like a shunt. Yeah. Or potentially, if the kidneys are not producing urine, we can do like amnio infusion, serial amnio infusion, or even amnioports. We can put a port, Mediport with a catheter to replace the fluid in these babies. And then postnatally, we can fix the rest.
Okay, thank you.
Yes.
Okay, thank you, Jose. And the last question, I think, from Gamal Al Said. Yes. Let's see here. Gamal Al Said.
Hello, good evening.
Yeah, good evening.
This is Jamal Saeed, is a professor of pediatric surgery at Al-Azhar University from Cairo, Egypt.
Yeah, we know you very well.
Very happy with this lecture from Mr. Peiro. This is the future of pediatric surgery, and we need to extend this experience all over the world. This is the future of pediatric surgery. Sometimes we found discrepancy between the prenatal surgery and postnatal surgery in diagnosis. I found personally a case of huge cystic teratoma and diagnosed prenatally, and postnatally it was huge anterior meningeal myelocele. And the management is usually different between the two lesions. Did you find any problem like this during your experience in this fetal surgery, and you changed your procedure from that to that? Thank you very much.
Thank you. So the question is, what's the finding you saw in this?
Usually there is discrepancy between the prenatal diagnosis and postnatal diagnosis in open traditional surgery. For example, we found discrepancies in huge cystic teratoma and the anterior meningeal myelocele.
A malignancy, you say?
No change, no malignancy. Cystic teratoma, huge cystic teratoma, usually difficult to differentiate between it and the anterior meningeal myelocele. And the surgical approach is usually different.
Got it. Yeah, you are right. You're right. Yeah, we found that. We found that. You know, sometimes we do, it's very similar, okay, in this area, sacrococcygeal area with a myelomeningocele. What we do is take a sample of amniotic fluid so we can determine the acetylcholinesterase, and this is positive, means that there is an open neural tooth defect. So the spinal cord is exposed, okay? So that's the way we differentiate even the skin closet spina bifida, also with the teratomas. And then with the fetal MRI, we can approximate very much, okay? And then postnatally, we can finish the treatment. So usually the cystic teratomas that are similar to spina bifida are really medium-sized, small, so they don't make a lot of trouble in the fetus. So we can confirm postnatally that it's a sacrococcygeal teratoma and do the appropriate surgery. Yes, that's possible.
Well, thank you, Jose, for this wonderful conference, I can say. Hope to see you in healthy days in person. I mean, I hope to see you someday in Turkey also.
Sure.
So thank you very much, and thank you for all.
Hear me anytime.
Yeah, and thanks to all the participants coming here, asking questions, very familiar faces, and we really like and hope to see them in healthy days in person, okay, not on the screen. Let me announce one more thing. Our next guest is Martin Laher from Leipzig, Germany. He will be talking about thoracoscopic repair of congenital diaphragmatic hernias on the upcoming Wednesday. Again, 9 p.m. Turkish time, Istanbul time. So bye to everybody, and I'm finishing the session. So Jose, thank you very much again.
Thank you very much, Aydin. Thank you very much, Jose, and regards to your family.
Sure. Thank you, Muntar. Bye.
Bye-bye.
Bye-bye.
Abdullah, how are you?
Alhamdulillah, very good to see you. You lost weight, you look good.
Good to see you. Yes, I did.
Can we get the record of this lecture?
Yeah, I recorded the lecture. Yeah. Bye-bye.
Thank you, Aydin. Thank you all very much.
Thank you, Professor Shalabi. Bye-bye.